Hi, my name is Yara Salman. I am a psychiatrist at City of Hope, which is a national cancer center in Duarte, California. And I will be talking to you today about some of the most common diagnoses one can encounter in patients with cancer. Let's start off by what happens when patients first get diagnosed with cancer. The initial psychological response can range anywhere from disbelief through denial, sense of despair, profound fear or sadness. The intensity of these emotions can fluctuate. All of these emotions are very common and can last anywhere from several days to weeks, and for some patients, even months. However, the trajectory of cancer is challenging not only in the beginning after the initial diagnosis of cancer, but throughout the treatment and then throughout the time of survivorship. And for different patients, these times can bring on different challenges, and every one of these stages can bring unique challenges and unique reasons for stress. Most people tend to adapt to their new diagnosis with additional support from their family and from their friends and from their treatment team, and they can prepare to get through the tough times of treatment. And for many patients, then the initial emotions will subside and they can either return to baseline or find some ways to adjust to their so-called new normal. For some patients, the initial stress, or what we would call a normative distress response, can evolve into a so-called adjustment disorder, which is actually one of the most common diagnoses in patients with cancer. And we can think about it as kind of a crossroad where patients either get better with time and additional support, perhaps through counseling, whether it's individual or group counseling or spiritual counseling and so forth, or their symptoms may actually worsen and evolve into more serious psychiatric disorders such as major depressive disorder or some of the anxiety disorders such as panic disorder or generalized anxiety disorder. When we think about an adjustment disorder, we think about a patient who is experiencing a significant amount of distress that is in excess of what one would normally expect in a given situation. But unfortunately, we don't really have any standards to describe what is considered to be abnormal and in excess of what would be a normal experience. But we could say that an excessive amount of distress is distress that's almost daily, that is intense. It is impairing the patient functionally, and it is a response to an identifiable stressor. Intense and untreated psychological distress can be associated with decreased satisfaction and participation in treatment for patients. It can increase patients' desire for hastened death or even physician-assisted suicide, and it can certainly reduce their overall quality of life. Within cancer care, it is well known that distress is common and screening for psychological distress is important and nowadays actually considered to be part of standard care for patients with cancer. Although there are multiple distress screening tools out there, if one would want to screen specifically for symptoms of depression and anxiety, it will be perfectly fine to utilize the GAD-7 screening instrument or PHQ-9. Both of those instruments are actually available in multiple languages and are free to use. Just to remind you, these are screening instruments specifically for anxiety and depression. But there are other distress screening instruments out there that can be used for patients with cancer. One of them, called the distress thermometer, is one of the oldest ones that actually allows the patient to rate their distress on the scale from 0 to 10, and they can also identify what are some of the most important causes of distress, whether it's their physical health or pain or financial concerns and so forth. So in summary, emotional distress in patients with cancer is very common. It is important that we identify emotional distress with proactive screening, and that is nowadays considered to be part of standard cancer care. Most of our patients will be able to adjust and cope appropriately with their circumstances, but there will be some who may develop more serious psychiatric symptoms, and we need to be able to diagnose and treat those appropriately. Let us talk about depressive disorders and the risk of suicide in patients with cancer. Depressive disorders are highly prevalent in patients with cancer, probably 2 to 3 times more prevalent than in general population. Although depressive thoughts and symptoms may be present in up to 50% of cancer patients at any point on their cancer trajectory, only about a quarter of them will actually meet the criteria for a major depressive disorder. One of the most basic questions that can start a conversation about possible depression with the patient is a question about patient's mood in the last 2 weeks. So we can ask them, how would you say your mood has been in the last 2 weeks, and hope that the patient will be able to share and elaborate. Or we can ask them directly, have you been feeling down, depressed, or hopeless most of the time over the last 2 weeks? This is the first question that allows us to screen whether the patient may be depressed. If the patient responds yes to this question, then obviously we want to follow this with other questions, screening for additional symptoms of major depressive disorder. Particularly in medically ill, we want to make sure we think about other possible diagnoses that could present as depression, but are not necessarily a major depressive disorder. And that could be an adjustment disorder with depressed mood, meaning the patient has some depressive symptoms, but they're not actually meeting the criteria of a major depressive disorder. This could also be a comorbid substance use disorder, for example, opiates or alcohol, which we know are depressants. Or there could be medications, for example, steroids, that could be causing depressive symptoms. Patients could have depressive symptoms due to another medical condition, for example, untreated hypothyroidism or significant B12 folate deficiency. Or patient could be experiencing demoralization or significant grief. For patients who are in the hospital, if one works as a psychiatrist consultant, we may be asked to see patients for quote-unquote depression, but it is not until we evaluate the patient that we realize the patient is not actually depressed, but hypoactively delirious. So that's another very important diagnosis to keep in mind, particularly for patients who are in the hospital. Sometimes patients themselves may underreport or even consciously disguise depressive symptoms. They may feel like it would be shameful to talk about that, it would make them look weak, or that the visit with the oncologist has to be focused on the medical illness. This is another reason why proactive screening for depressive symptoms or for distress in general are so important, because we are basically inviting the patient to tell us how they're doing emotionally rather than waiting for them to open up about that, which they may be very reluctant to do. Some of the risk factors for depression in patients with cancer include younger age, personal or family history of depression or history of trauma, comorbid substance use disorder, certainly any additional stressful life events or recent losses, perceived low social support. So in reality, the support may be sufficient, but if the patient perceives it as low, as insufficient, that may contribute to them feeling depressed. Personal attitude, patients with low self-esteem, feeling ambivalent about expressing negative emotions, people who tend to be more pessimistic, they may struggle with depression more often. Patients with advanced disease, some patients with particular cancer sites, for example, lung, head and neck, pancreatic disease, brain cancer, may be more likely to suffer from depression. And last but not least, physical disease burden, particularly symptoms like fatigue or poorly controlled pain. DSM-5 is very clear about the criteria for a major depressive disorder. We know that 5 or more symptoms have to be present. during the same 2-week period, and at least one of those is either a pervasive depressed mood or a loss of interest or anhedonia. The additional symptoms that we're looking for in patients with cancer are changes in weight. Oftentimes that will be loss of weight, changes in sleep, particularly insomnia or hypersomnia, changes in psychomotor activity, psychomotor retardation, slowing down, profound fatigue, feelings of worthlessness or excessive guilt, and this should not be just a mere self-reproach about being sick, a diminished ability to focus or a sense of indecisiveness, and for some patients, it could be recurrent thoughts of death and suicide. So actual thoughts about wanting to die or even thinking about how one could end one's life. So just fear of dying doesn't necessarily meet this criteria. Some of these symptoms, for example, changes in appetite, energy, sleep, can be due to either the underlying disease or sometimes cancer treatment. But when it comes to diagnosing major depressive disorder, we want to take an inclusive approach. So even if fatigue is due to the cancer itself or due to treatment, but the patient has other emotional, cognitive symptoms of major depression, we do include changes in appetite, energy, sleep in the diagnostic criteria. It is also very important to distinguish between fatigue as the symptom of depression as opposed to a symptom of cancer or treatment. One can encounter patients with cancer, either active or in a stage when they're done with their treatment, but they continue to struggle with chronic fatigue, which is not uncommon. And they will say that they feel down about their situation. However, they have a motivation and desire to do things. They really want to be out and about, but physically, they don't feel like they can. And that's a fundamental difference between those patients and patients who are profoundly depressed, who actually lose the interest in doing things that they previously enjoyed doing. As far as suicide, suicidal ideation is very, very common in patients with cancer, particularly the first few months after the diagnosis and particularly in men. Although the actual act of committing suicide in cancer patients is relatively rare compared to the number of patients who actually report suicidal ideation, patients with cancer have approximately twice the risk of suicide compared to general population. Probably the most common ways people with cancer end their lives is by overdose on sedatives or opiates. Some of the risk factors for suicide in cancer include demographic risk factors. Similarly to general population in the United States, the higher risk is in elderly males, patients who have untreated depression, profound sense of hopelessness and helplessness and feeling like they're a burden to others, poorly controlled physical symptoms, particularly pain, patients with cognitive dysfunction, limited social support, some patients with particular personality traits, especially people who really value having a lot of control over their situation and over their life, may feel particularly distressed and at risk for self-harm. For some patients who are existentially distressed, spiritually distressed, this may also lead to an increase in suicidal ideation and risk of suicide. Patients whom we might consider to be at a higher risk, but not imminent risk of suicide, I think it is important that we partner with their family members to hold and administer the medications, for example, opiates and or benzodiazepines that could be potentially lethal in overdose. And of course, referring these patients to appropriate resources to help them mitigate their suffering. So if the main contributor to patients' distress and their suicidal ideation is poorly controlled pain, we want to make sure that we help them with their pain. In summary, depression, including major depressive disorder, are common in patients with cancer and often under-recognized, underdiagnosed, and hence undertreated. Proactively screening for depressive symptoms can help us identify patients who may need further treatment. Suicidal ideation is common in patients with cancer. Proactively screening, proactively asking patients about having suicidal ideation can help us to identify those who may need further help and referral to additional resources. Patients who suffer significant physical decline and have poorly controlled symptoms, especially pain, can be at risk of suicidal ideation and increased desire for hastened death and suicide. So we want to make sure that we ask patients about how they're doing, how they're feeling, how they're coping with their symptoms, and implement appropriate preventive measures. When we're making a diagnosis of depression, we also want to keep in mind that patients may be struggling with grief or a sense of demoralization rather than clinical depression. Grief is a distinct entity in and of itself. It's a universal and highly personalized response to loss. It is a normal human emotion that is adaptive, and for some patients may overlap with major depression. Patients who are grieving may endorse symptoms of depression, but grief typically is not as persistent as feelings of depression or sadness. In depression and clinical depression, we see more of pervasive hopelessness, helplessness, feelings of excessive guilt and worthlessness, lack of pleasure or so-called anhedonia, and even suicidal ideation. The concept of demoralization has been introduced in the literature as a form of existential distress, as an experience where the patient loses a sense of hope, has a loss of morale, and usually over the period of 2 weeks or more, patients may endorse feelings of meaninglessness of life, feelings of hopelessness, helplessness, having difficulties with coping and meeting the expectations of self or others. They may endorse feeling like a failure or their life is pointless. And this sense of demoralization can often then fuel a desire to die sooner or even commit suicide. Patients who are socially isolated, who may have reduced social functioning, who may have poorly controlled physical symptoms, or poorly treated anxiety, depression, or comorbid substance abuse may be at a higher risk of feeling demoralized. What the treating team or treating psychiatrists need to keep in mind is that sometimes that feeling of demoralization can be quote-unquote contagious and can impact the overall decision-making process. Physicians, and particularly oncologists, can really help patients by proactively asking them about how they're coping emotionally. Just extra few minutes of clinic time to allow the patient to express their sadness or their fear and feeling like they're being heard by their oncologist who really cares about how they feel can be therapeutic in and of itself. Validating the patient's fears and sadness can help them relieve some of that pressure that they may be feeling, or even shame about feeling down. A couple of therapeutic approaches that have been actually developed specifically to help patients with this kind of existential distress and loss of meaning are meaning-centered psychotherapy and dignity therapy, which I would recommend to look into and read about because the concepts are usable with any patients, not just for patients with cancer, but with any patient who struggles with chronic, serious medical illness. Now, what happens if we leave the patient with their depressive symptoms untreated? If we simply don't diagnose it or don't treat it? Well, the patient who continues to struggle with cancer and depression will likely have a poorer quality of life. Depressed patients have lower adherence to medical interventions. Their physical symptom burden is increased. So when we're depressed, it's much harder for us to tolerate when we have pain or nausea. The physical symptoms of depression can lead to the alteration of cancer treatment. So if the patient is depressed and not eating, they may lose weight. They may not be nutritionally ready to handle a higher dose of chemotherapy. So the oncologist may decide that they need to lower the dose of chemotherapy. Depressed patients tend to have longer hospital stays. They may have more difficulties to understand and process the information about their disease, prognosis, and treatment because our cognition changes when we're depressed. As mentioned a few times already, patients who are depressed may have a desire for hastened death or even suicide. And needless to say, untreated depression has a significant impact on interpersonal relationship and can impact the quality of support that patients get. We also want to keep in mind that there are medications that can be contributing or causing depressive symptoms. I've mentioned earlier chronic opioid use, steroids, particularly higher doses of steroids, some of the antihormonal agents, and some of the chemotherapeutic agents as well. For example, tamoxifen, commonly used in breast cancer patients. In summary, it is very important to differentiate a major depressive disorder from other emotional states that can present with depressive symptoms, but don't constitute a major depressive disorder, particularly normal grief and sense of demoralization. We also want to make sure that we rule out the impact of any medications, cancer treatment, metabolic or endocrine or other medical issues that can masquerade as depression. Ask patients about how they're coping, validate their concerns, and refer them to appropriate resources. How can we treat depressive disorders in patients with cancer? Well, similarly to treating depression in other patients, we do want to make sure that we educate patients about the symptoms of depression, the diagnosis, and the forms of treatment. Sometimes just the education itself can have a therapeutic effect and provide the patient with the relief of understanding of what's going on with them and why they're feeling the way they're feeling. Some patients may opt just for psychotherapy, and there are different forms of psychotherapy, including cognitive behavioral therapy, mindfulness-based therapies, or meaning-centered psychotherapy, whatever is appropriate and the best fit for a particular patient. Some patients may prefer spiritual counseling. In addition to these therapeutic modalities, there will be a subset of patients that can benefit from an antidepressant, usually patients who have depression at a moderate to severe level. We want to educate patients that antidepressants are not addicting. That's one of the most common fears that patients have and one of the most common barriers to them accepting the treatment. I'll talk a little more about the antidepressants and what are the general principles of prescribing antidepressants in patients with cancer. I would suggest that you take a similar approach one would take to a geriatric patient. So start low and go slow. Obviously, if you have a patient where going slow is not appropriate and you need to be a little more aggressive with your titration, perhaps it's a younger patient who can handle that, then absolutely that is appropriate to do. But overall, we do want to be careful. We want to remind the patients that the effect of the medications takes a few weeks. It is important to provide the patient with a regular follow-up, whether it's a phone call or office follow-up. As we know, patients sometimes self-discontinue medication if they experience side effects that they don't understand or they feel that they cannot tolerate. Or some of them may not feel better right away and they stop the medication assuming that it's not working. So we want to follow up with the patient and we want to keep an eye on them and titrate the medication further up as appropriate. Once the symptoms have remitted, or at least most of them remitted, so we have at least a 50% remission and improvement, we want the patient to continue on the antidepressant for some time. I generally counsel patients they should stay on the antidepressant for at least a year. If they have never had an episode of major depressive disorder before, then at 1 year of treatment, we can evaluate whether they want to continue or see how they do without the antidepressant. For patients who've had prior episodes of major depressive disorder, their chances of having another one are pretty high. So I may recommend that they continue on the antidepressant indefinitely as long as it's effective for them. If the patient does not respond sufficiently to one antidepressant, we should not give up and we should try another agent, even within the same class. Sometimes we can combine different agents from different classes, for example, an SSRI with bupropion or an SNRI with bupropion. Bupropion is a norepinephrine and dopamine reuptake inhibitor, particularly helpful in patients who struggle with fatigue and a lot of apathy, patients who are smokers and would like to stop smoking. This, again, may be a good agent to start with. As we know, it's not an antidepressant that treats anxiety, and in fact, anxiety can be one of its side effects, so we want to keep that in mind. If we have a patient who has depression but also a lot of anxiety, this may not be the best first-line choice. And we also need to keep in mind the potential for a lower seizure threshold, particularly at higher doses. So patients who have brain tumors or history of alcohol use and are at risk of alcohol withdrawal, for those, this medication also would not be the best choice. Fluoxetine may be appropriate for some patients who, for example, are MPO or have an intermittent bowel obstruction because it is the longest acting SSRI and can be administered once a week. Some of the dose formulations may be preferable and determine which antidepressant one chooses to use. So, for example, pill versus liquid. SNRIs are commonly used, especially in patients who have comorbid neuropathy, which is a very common problem as a result of chemotherapy. SNRIs are a reasonable choice for depressed cancer patients with pain that is not completely responsive to opioids, as SNRIs can help with the perception of pain and may have a potential co-analgesic benefit. So duloxetine or venlafaxine or desvenlafaxine are the most commonly used antidepressants from this category. Venlafaxine is a first-line choice for patients with breast cancer who are on tamoxifen maintenance, as venlafaxine does not have any 2D6 inhibitory action, and therefore it is safe to combine. You could say the same about desvenlafaxine. We want to avoid duloxetine in patients who have hepatic or renal disease. Levomelnacipran has been used as an antidepressant in Europe, but in the United States, it's only indicated or approved for fibromyalgia. Another very commonly used antidepressant in patients with cancer is mirtazapine. Mirtazapine is a serotonin and norepinephrine increasing antidepressant that is also possible to administer as a sublingual orally disintegrating tab, which can be very beneficial for patients who have trouble swallowing, for example, due to painful mouth sores. It is a pretty sedating antidepressant, so we use it also as a sleep aid for some of our patients at 7.5 or 15 milligrams. I prefer to use mirtazapine or trazodone for sleep rather than a benzodiazepine or other so-called Z drugs because of the lack of addiction potential. Mirtazapine can also help some patients with nausea and appetite stimulation. One thing to keep in mind is that there have been case reports of neutropenia with mirtazapine. Some of the older antidepressants, like tricyclic antidepressant amitriptyline, nortriptyline, are generally not used as first-line treatment of depression or anxiety in patients, but you may still see them used by our colleagues in neurology or supportive medicine for management of neuropathy or chronic headaches. Some of the most common side effects, particularly initially in treatment, include nausea, diarrhea, headache, tremor, changes in sleep. For some patients, it can be sleepiness, or for others, it can be insomnia. Hyponatremia or bleeding abnormalities are relatively uncommon. We want to keep in mind possible drug-drug interactions. SSRIs in general have low drug-drug interaction potential, with the exception of paroxetine and fluoxetine, which are both potent 2D6 inhibitors. As we know, citalopram has a warning about QTc prolongation, as citalopram is a similar medication which does not carry the same warning. If the patient wants to stop the antidepressant, it's always better to taper it off gradually, particularly antidepressants like paroxetine or venlafaxine. Some of the other agents to consider include medications like stimulants. So, for example, methylphenidate at doses between 2.5 to 10 milligrams per dose can be very helpful. For patients who are profoundly depressed, very low energy, you really need them to start engaging with physical therapy, occupational therapy, and you cannot wait those 3-4 weeks for the SSRI or SNRI to kick in. For those kinds of patients, adding a low dose of stimulant may be very helpful. If methylphenidate is not doing the job, you can try other stimulants, for example, from the group of dextroamphetamines. All of these medications are really rapidly acting for fatigue, apathy, and mood, and may actually be a good choice for patients who are terminally ill, who cannot really afford the time to wait for a typical antidepressant to work, as stimulants may really improve their mood much more rapidly. I do have patients who don't necessarily struggle with depression, but do struggle with significant fatigue, for whom I would use a low dose of stimulant for that purpose. Ketamine has become more and more popular in treatment of depression in the general population. It is a drug that has been used in general anesthesia. It's an NMDA antagonist, and at a low dose IV administration can actually rapidly relieve treatment-resistant depression. However, the duration of the effect can vary widely, and the doses often need to be repeated. In patients with cancer, we don't really have a lot of data on the use of ketamine, but there are certainly patients for whom this may be an appropriate alternative. For example, patients who are terminally ill or patients who have ongoing pain issues where ketamine could help them with both pain and depressive symptoms. As a second line, I would think about modafinil, which is a medication with dopamine-enhancing effect. Sometimes the cost of the medication can be a barrier for patients to use it. In summary, antidepressants are the first-line treatment, particularly for moderate to severe forms of depression. Favorable side effects and possible effectiveness for other symptoms, for example, hot flashes or pain, should also be taken into consideration when we are selecting an antidepressant. Some non-antidepressant agents, such as stimulants, can often be used safely and effectively as an augmentation of antidepressant treatment, especially in the first weeks of starting an antidepressant, or for patients who have chronic significant fatigue or chemotherapy-induced cognitive issues, such as difficulties with focus. Anxiety is a very, very common symptoms in patients with cancer at any point on cancer trajectory. As you can imagine, patients with cancer have so many reasons to worry. They commonly worry about their prognosis. What's going to happen? Is my cancer diagnosis a death sentence? Is my cancer going to spread? They commonly worry about recurrence. Fear of recurrence or progression of disease is a very, very common fear. For some patients, those thoughts may pop up once in a while, but otherwise they're not bothered. They can go about their life. But there are patients for whom this anxiety is so intense and so frequent that it's hard for them to function and focus on anything else. It may be hard for them to sleep and so forth. Those are the patients that we really want to pay attention to and help them out. The prevalence of anxiety is estimated to be anywhere between 10 to 30% of patients with cancer, depending on how we screen for it and who we're asking about anxiety. Sometimes the patients meet the diagnostic criteria of a generalized anxiety disorder, except the duration criteria. So they could present with a lot of the symptoms of GAD, but not necessarily symptoms that have been lasting 6 months. So we need to take a sort of a tailored approach to these patients who are really struggling. And even if they have not been struggling for 6 months because they got diagnosed with cancer 4 months ago, and since then they've having all these anxiety symptoms and sleep disturbances and muscle tension and irritability and difficulties focusing and so forth, it does not mean that we should ignore it or that we should not try to treat those symptoms. If we want to screen for anxiety, GAD-7, Generalized Anxiety Disorder 7-item screening instrument, is one of the ways that we can ask about anxiety. When we think about anxiety in patients with cancer, we think about a disproportionate level of anxiety that is pervasive, almost daily, or recurring often and at intense level. Those are the kinds of symptoms that really deserve our attention and an attempt to diagnose and offer some form of treatment, some form of relief to patients. It seems that particularly younger patients and female patients, patients from lower socioeconomic status, separated, divorced, with those patients with limited social support, may be at increased risk of anxiety. Untreated intense anxiety can actually increase patients' risk for suicidal ideation and suicide. For some patients, a particular procedure can cause anxiety. Many will say the few days, and particularly the night before they come for their CT scan, their anxiety is through the roof. Patients who are anticipating the start of chemotherapy or their bone marrow transplant, or patients who are waiting for the results of their most recent scans or laboratory results, all of those patients will experience some degree of anxiety that for many will subside once they know the results. But leading up to that particular time, the anxiety can be really intense. Some patients may experience anticipatory anxiety and nausea following chemotherapy. This is a pretty common issue where patients were very nauseous with their chemotherapy. The chemotherapy is done and over, for example, but every time the patient comes to clinic, they may experience anxiety and nausea as a response to the reminder of what they experienced before. Or the chemotherapy is ongoing, but each dose or each infusion of chemotherapy is causing them to have anticipatory anxiety and nausea. Sometimes anticipatory anxiety and nausea can be treated with a low dose of lorazepam. There will be patients who've already had a history of generalized anxiety disorder, which may have been in remission or partial remission, but now the symptoms are exacerbated because of the cancer diagnosis. Similarly, with panic disorder, patients who've had panic attacks in the past may now have recurrent and frequent panic attacks again. If you have a patient who has social anxiety disorder, they may have difficulties advocating for themselves as patients with cancer. Patients with specific phobia, particularly claustrophobia or blood injection phobia, may have a really hard time with these procedures. And we may need to help them with either medication and or cognitive behavioral therapy. There are patients with cancer for whom the diagnosis or the treatment can be very traumatic, and they may experience and complain of symptoms like intrusive memories, hyperalertness, nightmares. Anxiety may be triggered by driving by the cancer center or having to come to the cancer center. Many of these patients do not have a full-blown post-traumatic stress disorder syndrome, but they may have elements of that syndrome as a result of their experience with cancer. We also want to make sure that we think about other possible diagnoses. For example, poorly controlled pain is a common cause of significant anxiety, and once the pain is controlled, their anxiety resolves as well. Respiratory distress is incredibly anxiety-provoking, so patients who are hypoxic, who have possibly an underlying PE, or other causes of shortness of breath or respiratory distress are going to feel very anxious. We don't want to attribute that to a panic attack when in fact the patient has some kind of underlying serious respiratory issue. Patients being weaned off of ventilatory support can have a lot of anxiety. Some of the endocrine conditions like hyperthyroidism, hypoglycemia, hypocalcemia, or hormone-secreting tumors can cause anxiety. Some medications, particularly medications like corticosteroids or bronchodilators, can cause anxiety. Or prochlorperazine, which is commonly used for nausea, can cause significant anxiety. Patients withdrawing from substances such as alcohol or benzodiazepines or opiates are often very anxious. Patients may worry about their functional status and potential loss of income or transportation, how they're going to make it to their appointments. Many of our patients live far away from our cancer center. And for many of them, the cost of gasoline or access to reliable transportation are a significant concern. Imagine a patient who's coming for chemotherapy and they're tired. They may have some medications in them that cause them to be sedated, so they need somebody to bring them in and take them home. It's not an easy arrangement for everybody. That sort of dependence on others for help can cause a lot of anxiety for patients. Sometimes just the pressure to constantly think positively can be a source of anxiety for our patients, paradoxically, right? They feel like they have to meet up the expectation of being absolutely and always positive, which is not a realistic expectation and not possible. They have a lot of reasons to be sad, to be worried, and they need the opportunity to share that openly. Akathisia, or significant inner restlessness, is a distinct symptom that's very different from anxiety, although patients may endorse it as anxiety, but it's a very, very uncomfortable, unpleasant sense of inner restlessness and urge to move. Akathisia can be caused by prochlorperazine or metoclopramide, so medications that are used for management of nausea. In summary, anxiety is one of the most common symptoms of emotional distress encountered in patients with cancer. When anxiety is excessive in duration or intensity, it can certainly interfere with patients' ability to cope and to participate in treatment. For example, when they have severe claustrophobia or anticipatory anxiety, they may even avoid coming to their appointment because they're so anxious. Other potential causes, including the effects of some of the medications, or underlying medical issues may present with anxiety. How can we treat anxiety disorders in patients with cancer? Similarly to the treatment of depressive disorders, anxiety disorders can be effectively treated with different forms of psychotherapy, particularly cognitive behavioral therapy, but also by implementing and teaching patients techniques like relaxation or problem-solving therapy. For some conditions, hypnosis can be very helpful. As far as pharmacological treatment, the first-line treatment of anxiety involves antidepressants, so SSRIs, SNRIs, or mirtazapine. For some patients, concomitant use of benzodiazepines can be very helpful, particularly initially, while we're waiting for the effect of antidepressants. Benzodiazepines can be helpful for patients who have significant acute anxiety or a panic disorder. They are relatively widely used in cancer patients. I, in my practice, tend to lean on lorazepam or clonazepam, and I always prefer to use them only on an as-needed basis. Very rarely do I use any of these drugs routinely, and if so, only for a short period of time, and only for patients who are not exhibiting any signs of delirium. We need to keep in mind the potential side effects of benzodiazepines, such as oversedation, drowsiness, ataxia, and precipitating or worsening of delirium. We want to be particularly careful about using benzodiazepines in patients who are elderly. Antipsychotic medications such as quetiapine or olanzapine do not have an FDA approval for treatment of anxiety, but at low doses they may be helpful in patients who are both anxious and confused, so likely delirious. They can also be useful in patients with respiratory complications, as antipsychotics do not cause respiratory depression. As I mentioned earlier, many of our patients struggle with fear of becoming addicted to psychiatric medications. And here, education about the purpose of medications, how they work, and what it means to take them is very important. When approaching patients with depression or anxiety, or both, because many of our patients do present with both depression and anxiety, I would recommend that we approach each patient with a good dose of cultural humility. We know that patients who come from non-majority groups tend to report less satisfaction with treatment, less shared decision-making, and less overall trust of their providers. We know that disparity can be exacerbated by racial, ethnic, or linguistic discordance between patient and the doctor. and also by patients' past experiences of discrimination. There is still a lot of stigma in seeking psychiatric care, particularly in certain groups. Although depression is a well-accepted concept in European and North American cultures, in many non-European cultures, it's hard to find the equivalent concept. And in many cultures, it is actually part of a normative presentation that patients present more with physical symptoms. They may underreport emotional, cognitive symptoms of depression. And that may lead also to a lack of motivation to receive sort of a standard Western psychiatric treatment. In some cultures, in some ethnic groups, somatization, so presentation with somatic symptoms, can actually be more acceptable. Many of our patients who come to us or who are meeting with their oncologist who may suggest to go and see a psychiatrist may fear that if they do, they're going to be labeled, quote unquote, crazy, that there is something really wrong with them. And we want to address that, and we want to reassure them that we want to help them, and our goal is to decrease their suffering. In conclusion, primary anxiety disorders, for example, generalized anxiety disorder or panic disorder, are usually treated with antidepressants. Benzodiazepines should ideally be used only for short-term and on an as-needed basis. And other modalities of treatment, such as cognitive behavioral therapy or hypnosis, can also be very effective interventions for anxiety. One of the most common neuropsychiatric complications in patients with cancer is delirium, particularly in patients who are hospitalized. Delirium is often a serious neuropsychiatric complication. Delirium as a clinical syndrome has actually been first described by Celsus in the 1st century CE. And then in the 19th century, an English physician, Thomas Sutton, coined the term delirium. But it wasn't until 1980 when the DSM-3 actually introduced a formal clinical definition of delirium. You may have encountered other names basically for the same syndrome, such as quote-unquote ICU psychosis, metabolic encephalopathy, acute confusional state, acute brain failure, reversible dementia, or in palliative care, terminal restlessness. All of these different terms basically refer to the same syndrome of delirium, and some of them can be confusing. I would actually recommend to avoid the use of different terms. Using the term delirium is appropriate. As far as the prevalence of delirium, it very much depends on the population. So, for example, up to 50% of elderly patients who are post-surgical may experience delirium. 20 to 40% of patients who are admitted to palliative care unit may exhibit delirium. Up to 45% following the admission to palliative care can develop delirium. Patients who are terminally ill, who are in the last hours or days of their life, over 80% of them can be delirious. Roughly the same prevalence applies to patients who are in the ICU. As far as patients who are actively dying, for some of them, it can still be a reversible complication, but for many of them, it isn't. What are some of the predisposing and precipitating factors of delirium in patients with cancer? When we think about the predisposing factors, some of them are not modifiable, meaning that there's nothing we can do about them. So those are things like patient's age, elderly patients, 65 and up. That in and of itself increases the risk of them becoming delirious. Patients who have an underlying cognitive impairment such as dementia, and those who have coexisting medical conditions such as chronic liver or kidney disease or are terminally ill. Patients who have a history of delirium, who have a history of falls, history of alcohol or substance abuse, history of stroke, history of fractures or trauma. Those are examples of non-modifiable predisposing factors. Patients may have additional predisposing factors that are actually modifiable, meaning that we can do something about them. And those are important because if we do something about them, we could actually help prevent delirium from evolving. And those are things like malnutrition, dehydration, infection, reduction of functional performance status, organ dysfunction or failure, severity of illness, things like visual impairment, hearing impairment, or polypharmacy. Those are all things we can actually screen for, evaluate, and address. If we do that in time, we may help prevent delirium from developing. Predisposing and precipitating factors are similar or even overlapping. And that's just the reality of it, that there are patients who already come with a package of predisposing factors, and they don't need much more for delirium to be precipitated, particularly when it comes to elderly, sick, fragile, vulnerable patients. Elderly patients who have dementia, all they need to happen to them is to have a UTI or pneumonia, and they become delirious just by adding that one infectious complication. The precipitating factors, so factors that actually lead to precipitation of delirium, also can be non-modifiable and modifiable. Modifiable precipitating factors include things like medications, for example, anticholinergic drugs, or opiates, infections, hypoxia, shock, fever, anemia, dehydration. How does delirium actually happen, and what's going on in the brain when it happens? The brain dysfunction is a result of usually a combination of an underlying medical issue, whether it's a metabolic abnormality or an infection or some kind of inflammatory process or the effect of medications or withdrawal substances. So we're talking about all of these various etiologies that can actually lead to neurons being dysfunctional. And what that looks like clinically is the clinical syndrome of delirium. If you do an EEG on your delirious patients, there is a diffuse slowing on EEG. So it's a very nonspecific finding that actually just tells us that the brain is not functioning properly. There is likely a functional disconnect between various brain areas and an imbalance of various neurotransmitters. So typically acetylcholine and dopamine, serotonin, norepinephrine, glutamate, histamine, GABA. We know that some of the deliria, for example, alcohol withdrawal delirium, is often a hyperactive, agitated type of delirium, and that the issue there is an acute GABA withdrawal. For some other types of deliria, for example, the effect of anticholinergic medication on patients who have dementia and decreased acetylcholine reserve, they can also develop delirium. There, the problem is the lack of acetylcholine and anticholinergic effect. So different etiologies can lead to different forms of brain dysfunction as far as which areas are involved and which neurotransmitters are involved. One of the theories that may explain at least some of the deliria that we see in our clinical practice is neuroinflammatory hypothesis that is based on the activation of neural inflammation within the brain that occurs as a result of systemic inflammation. So, for example, if you have a patient who is elderly, who just had surgery, maybe they have an infection as a complication. So in their body, there is an activation of systemic inflammation, and the inflammatory cytokines, such as TNF-alpha or IL-6, get through the blood-brain barrier that is already weakened by the older age, inflammation, anesthesia, or anticholinergic medications. And these systemic inflammatory cytokines get into the brain, where they lead to the activation of microglia and the release of further inflammatory mediators in the brain itself. And that neuroinflammation causes neuronal dysfunction. And in worst case scenario, even neuronal death. So the neuronal dysfunction then presents as acutely developed delirium. One of the possibilities, not a common but nevertheless possible complication of cancer, is leptomeningeal disease. which means that the cancer had spread to the meninges of the brain and the spinal cord. This usually happens in terminal stages of the disease and is usually accompanied by delirium. If the neurons or most of the neurons recover from this dysfunction, then we have a picture of delirium of a relatively short duration. However, if the dysfunction of the neurons persists, then we have a delirium of long duration, unfortunately. And if the neuroinflammatory insult and the damage to the neurons is significant enough, patients can come out of the delirium but present with significant cognitive dysfunction. And for some patients, particularly for those who already had a history of cognitive impairment, this can actually result in dementia. In summary, delirium is highly prevalent in patients with cancer, especially in those in the final weeks of terminal illness. Delirium is a neuropsychiatric syndrome with a wide variety of symptoms. The care of delirium symptoms include acute change in mental status, inattention, and fluctuating course. There are many predisposing and precipitating factors that contribute to the development of delirium. It is important to identify patients who are at risk and, to the extent that we can, minimize or modify the risk factors. Prevention of delirium is the preferred strategy. The pathophysiology of delirium is very complex, and possible causes are many and often overlapping. An imbalance of neurotransmitter activity and inflammatory activation likely play a significant role in many of the cases of deliria that we encounter in the oncology setting. How do we diagnose delirium in patients with cancer? Well, our diagnosis is generally based on the DSM-5 criteria for diagnostic definition of delirium, which include 5 key features. Number 1, there is a disturbance in attention and awareness. 2, this disturbance develops over a short period of time and represents a change from baseline and tends to fluctuate. There's an additional disturbance in cognition, such as memory, language, perception, or visuospatial. So delirium is characterized by abrupt onset of disturbance in awareness, attention, cognition, and perception that tends to fluctuate over the course of the day. The first 2 criteria are not better explained by another pre-existing or evolving neurocognitive disorder and do not occur during coma, and there is evidence of direct consequence of another medical condition or substance intoxication or withdrawal or toxins or multiple etiologies. I would add that one of the hallmark symptoms of delirium is inattention. So if you have history of acute change in mental status, their mental status tends to fluctuate, and on your exam, they're having a really hard time attending. They're easily distracted, forgetful, repeating themselves. You have to repeat the question. You need to have a high suspicion for delirium. As far as the timing of symptoms, we can think about delirium as an acute condition that generally lasts few hours to days. But for many patients, particularly very sick patients, delirium can persist even over the course of weeks and months. The DSM-5 identifies motor subtypes of delirium, hyperactive delirium, where typically the patient tends to be agitated, trying to get out of bed, pulling their lines. They can be aggressive towards staff. Or hypoactive delirium, patients present as apathetic, lethargic. They may appear depressed or withdrawn. Many patients may exhibit mixed forms of delirium, so there can be alteration between hyperactive and hypoactive state. We get consulted to see patients who may present with a lot of agitation. The history obtained from the nursing staff and from the family, as well as reports by occupational therapy, laboratory review, and mental status exam can help us then determine what kind of delirium the patient is presenting with. Again, hyperactive or hypoactive, and in some patients, there can be a combination of the two. Delirium is a diagnosis of privilege, which means that in the setting of delirium, we should not make any other psychiatric diagnosis at that point. So, for example, if the patient is hypoactively delirious, we should not be simultaneously diagnosing them with depression. We should wait for the delirium to resolve and then evaluate the patient for presence of depressive symptoms. Delirium is also called the great imitator because misdiagnosis is very common in patients who are delirious and being misdiagnosed with some other psychiatric disorder or neuropsychiatric disorder. There are cases where delirium presents as subsyndromal, meaning that one or more symptoms are present, but they never actually progress to full diagnosis of delirium. As an example, I would mention a couple of patients encountered in the hospital setting where it's not unusual for psychiatry to be consulted to evaluate the patient for depression. The presenting symptoms are apathy, lethargy, not engaging, refusing food or medications, having difficulties following instructions with occupational therapy. And then upon reviewing the patient's laboratory findings and brain imaging as well as EEG, and of course, based on the mental status exam where the patient presents as very somnolent and having a hard time answering questions, we realize that the diagnosis is actually delirium and not depression, which is a very, very important distinction. Delirium can be superimposed on dementia, and here collateral history from a patient's family or others who know the patient well about the patient's baseline and degree of change in mental status are very, very important. We have to keep in mind that the patient's confusion, agitation, or disinhibition are expressions of brain malfunction, so we have to be cautious about escalating opiates so that we don't worsen delirium. Why is it important that we talk about delirium, that we recognize it, that we try to prevent it as much as we can and intervene when possible? Well, we know that delirium, once it develops, is really difficult to treat unless we're able to find and actually treat the causes of delirium, which in some cases are multifactorial, difficult to manage. And once there is a neuroinflammation going on in the brain, it may be very difficult to control that. Patients who are delirious can self-extubate, they pull their lines, they can be agitated, they can be aggressive and difficult to take care of. They can scare their family members or even nursing staff taking care of them. Patients who are delirious tend to stay in the hospital longer, and so the cost of hospitalization, but also post-hospital recovery is certainly increased. Many patients who suffered delirium can require then additional institutional cares because they're functionally worse off than patients who did not have delirium and may have had similar medical condition. Delirium has a significant impact on patients' subsequent functioning because it's an independent predictor of cognitive decline. So even for patients who were cognitively doing well and intact prior to delirium, they may suffer from some cognitive impairment after the delirium resolves, let alone patients who already had a history of cognitive impairment, such as mild or moderate dementia. Delirium may push them even further down on their level of cognitive functioning. In summary, it is important to recognize evolving or developed delirium, especially in patients with less obvious behavioral changes, so patients with hypoactive delirium. The main course of treatment of delirium involves searching for possible causes and correcting those if possible. We need to keep in mind that delirium increases patients' overall morbidity and mortality. It can prolong their hospitalization and increase the risk of functional decline and dependence. And delirium can have a significant and long-lasting residual impact on patients' cognitive functioning. How can we approach the assessment of delirium in patients with cancer? Well, the assessment starts with the bedside assessment of the patient. As a psychiatrist, obviously, I entered the room and I look at the patient and can already gather information based on how the patient looks or how the patient behaves. And then during the interview, is the patient attentive? Is the patient able to keep track of the conversation? Do they seem to be perseverating? Are they really slow in processing the information? All of those cognitive, sometimes subtle signs can be indicators of delirium being present or even subsyndromal delirium being present. We want to actively ask them about hallucinations. Hallucinations in patients with delirium are often fleeting. Visual hallucinations can include seeing animals or people in the room. In some patients, you just enter the room and you see the patient picking something in the air that's not there. You have your diagnosis right there, or they're picking at the blanket. Delusions in patients with delirium are often transient. Some patients may disclose to you that they heard the nurses talking about them, or that there is a TV show that was talking about them, or somebody is plotting something against them. It could be one delusion one day and some different delusion another day, which is an important differential diagnosis from, for example, schizophrenia, where the delusions are fixed and it's usually the same thing that the patient experiences. So in delirium, keep in mind that hallucinations and delusions can fluctuate, and so can their content. As part of your mental status exam, you can include so-called mini cognitive exam, where you ask the patient about orientation, 3 words, immediate and delayed recall, and have them draw the clock. The patient who is delirious is going to have a really hard time with clock drawing. You may also examine the patient for the frontal release sign, so reflexes that would be abnormal in an adult patient. It is very, very important to obtain collateral history from the nursing staff, from the family members if they're present. What are they observing? When did all this start? Are the symptoms fluctuating? Are there times when things are better or worse, and so forth? In some places, nurses are engaged in routine assessment for delirium. So, for example, one of the screening methods is the confusion assessment method, or so-called CAM. The confusion assessment method is a pretty short and quick screening instrument. Staff who use this screening instrument should be properly trained on how to use it. And when it is used properly, it has a pretty high sensitivity and specificity. It does not measure delirium severity. It helps to screen for delirium based on the 4-item algorithm that requires the presence of acute onset and fluctuating course, inattention, and either disorganized thinking or altered level of consciousness. So if there is a history of an acute onset or change in mental status with a fluctuating course, then an additional feature would be disorganized thinking or altered level of consciousness, for example, lethargy or agitation. Testing for inattention can be very simple. You can ask the patient to name the months of the year backwards, starting with December. A patient with delirium is going to have a really hard time performing that task. Obviously, routine laboratory and imaging workup to rule out possible underlying causes of delirium is part of standard care. Depending on the patient's disease status, we do want to make sure that we search for any possible underlying common medical cause that could explain why the patient is delirious. And that would include things like head CT scan or brain MRI scan, chest x-rays, EKG, EEG, CBC-CMP, level of ammonia, oxygen saturation, looking for any signs of infection, including blood culture and urine analysis, thyroid panel, B12 folate, vitamin B1 levels, HIV, RPR, toxicology screen, and so forth. Of course, depending on your setting and your particular patient's case, there may be other additional workup that may be needed. If we have a patient who we know is in terminal stages of their disease and they become delirious, We want to make sure that whatever workup we choose to do is causing the least harm and discomfort to the patient. And sometimes it makes more sense to forego some of the procedures for the sake of patient's comfort. In summary, proactive screening for delirium can help identify patients who may otherwise escape detection. Appropriate laboratory and imaging workup is very important and imperative to make sure that we investigate for possible causes of delirium. As far as the management of delirium in patients with cancer, we have to have an individual approach to each patient and each patient's needs. Ideally, we would maximize our preventive efforts to minimize any patient's risk for developing delirium. About 50% of delirium episodes in patients with advanced cancer can still be reversible. We want to distinguish between cases where the delirium is part of the terminal stage, where the goal is to control symptoms, for example, pain or shortness of breath. In those cases, the delirium may not actually be reversible and may be part of the course of dying. However, if we have a patient who is not in the process of dying, they're not terminally ill, then certainly it makes sense to search for possible causes and reverse the etiology of delirium if we can, because the first line intervention and treatment is to identify and treat reversible precipitants. So those causes that led to the development of delirium. We want to be mindful of the interference of delirium with the assessment and management of pain. Patients who are confused, agitated, delirious may not be able to tell us how much pain they're experiencing, and we may have to look for other signs of patients being in pain. On the other hand, we also don't want to assume that patients are in pain and overtreat them with opiates that may worsen the patient's mental status. Non-pharmacological intervention is very, very important in preventing and managing delirium, such as making sure that the patient has appropriate oxygen delivery, that they're hydrated, that we correct the electrolytes, that their bowel and bladder function is appropriately attended to, that they have their visual and hearing aids, that we reorient them frequently, that we modify their environment as much as we can. So we keep the room well lit during the day, and we minimize the nighttime interruptions as much as we can. And also involving physical therapy and occupational therapy to mobilize the patient. So sitting up in bed or chair is better than just constantly lying down. Whatever we can get the patient to do is important to do so. Our pharmacy colleagues can help us identify and eliminate any drugs that could be contributing to delirium. For example, opioids, benzodiazepines, anticholinergic agents, or some other drugs that may be the culprit. Patients can be individually sensitive to some of these drugs. Whenever possible, we want to taper off or discontinue drugs that we think could be contributing to delirium. For example, benzodiazepines that are sometimes used for management of agitation can worsen the presentation of delirium. If we suspect that the patient's delirium could be caused by opioids, it makes sense to rotate or switch opioid agents. As far as pharmacological treatment, there are no FDA-approved medications specifically for treatment of delirium, but we quite often use antipsychotic medications. The goal of using the medications is to help the patients be awake, alert, calm, comfortable, and still be able to communicate with a family and staff. Of course, there are cases of patients who are so extremely agitated and so confused that even the workup, like getting the patient through the brain MRI or even head CT or doing an LP if that's needed, is impossible because of their agitation. For those patients, it may help to use more sedating agents to calm them down and allow this workup to be done. one of the most commonly and probably historically most commonly used antipsychotic is haloperidol, which has several advantages, including various ways of administrations like PO, subcutaneously IV. Haloperidol has fewer anticholinergic effects, does not have active metabolites, and can be safely used in medically ill patients. In our cancer patient population, we tend to avoid administering any medications via IM intramuscularly, including antipsychotics. So that's not a common practice for us, but it is pretty common to use haloperidol via IV, in which case you want to make sure that you're monitoring the patient's cardiac function and especially the QTc interval, because there is a risk of QTc prolongation. As you may know, the FDA had issued a black box warning on all of antipsychotics when used in elderly and particularly in patients with dementia, that they can increase risk of death in this patient population. If the patient has a brain tumor or metastases to their brain, high doses of steroids can help relieve those symptoms that could be due to surrounding edema. We generally recommend to avoid benzodiazepines and anticholinergic agents, with the caveat that benzodiazepines can actually have an important and helpful role in palliation of patients who are actively dying. So for those patients, we use benzodiazepines whenever that's appropriate and sometimes in combination with antipsychotic medications. Outside of that setting, benzodiazepines should be reserved for alcohol or sedative hypnotics withdrawal management. In summary, non-pharmacologic interventions have both a preventive and treatment importance in managing delirium. Medications that can trigger or worsen delirium should be discontinued if at all possible. Benzodiazepines should be reserved for management of terminal delirium, where antipsychotic agents are not sufficient for symptom control. Antipsychotic agents are used for symptomatic management, especially in cases of highly hyperactive, agitated delirium, but they can also be useful in some of the hypoactive cases, particularly in patients who have hypoactive delirium, but also are reporting hallucinations or anxiety. I would like to leave you with a few take-home messages after my presentation on anxiety, depression, and delirium. Please remember that psychological distress is common and can occur at any point on the patient's trajectory of cancer diagnosis, treatment, and survivorship. Most of our patients will be able to adjust and cope appropriately with their circumstances, but some may develop more serious psychiatric symptoms that should be diagnosed and treated appropriately. Active screening for distress, identifying sources of distress, and providing appropriate care to address those sources of distress is considered to be a standard of cancer care. Patients and their families benefit from a whole patient approach to their care. Antidepressants are the first-line treatment, particularly for moderate to severe forms of depression. Non-antidepressant agents, such as stimulants, can often be used safely and effectively as an augmentation of antidepressant treatment, especially in the early weeks of starting an antidepressant or for patients with chronic fatigue or chemotherapy-induced chronic cognitive issues. Benzodiazepines should ideally be used only short-term and on an as-needed basis. Delirium is a common complication, particularly in acutely ill patients with cancer. Unrecognized and untreated delirium can result in increased morbidity, mortality, and decline in functioning, including long-lasting cognitive impairment. Prevention of delirium by identifying and minimizing the risk factors should be part of a routine inpatient cancer care. Medications that can trigger or worsen delirium should be discontinued if at all possible. Antipsychotic agents are used for symptomatic management, especially in cases of highly hyperactive, agitated delirium, but they can be useful in some of the hypoactive cases as well. Thank you.